It's the AEMT lecture series. Welcome back, everybody. This will be video number 1 for Chapter 8, Physiology. So I'd like to welcome everybody back to the program. Physiology, right? It's my favorite. I enjoy it. I like to know how the systems work. And that's what we get here in physiology. We get to figure out how these organs work together, and we get to figure out when they're not functioning properly, maybe how to fix it, maybe how to catch it, maybe how to figure it out while we're observing, and while we're doing that patient interview to get their take on it. And then we come up with a plan to treat, blah blah, and it's fun. And so welcome. So physiology, the study of the physiology of altered functioning in the presence of disease. That's what we're talking about. So here's some definitions, and I'll probably know these because they're great, National Registry EMTA questions. So atrophy, right? So when we talk about atrophy, most of the time you don't hear it talked about so much in the description of cellular anatomy or physiology. Usually atrophy means like, patient has status post, status post paraplegic, and their muscles haven't been used in a while and they're atrophy. So anyway, right? So, but in this case, we're going to say atrophy is a decrease in the cell size, a loss of subcellular components. And then we have hypertrophy. Right? It's going to be kind of the opposite. We're going to increase the size of the cell. Right, and it could be because we got too much sodium inside the cell and it's attracting water, and that cell's getting larger or something like that. We have hyperplasia, and so when we talk about hyperplasia, we're talking about not necessarily the size of the cell, but maybe numbers of cells. All right, and then we have dysplasia. Dysplasia means it's an alteration in the size or the shape or how the cells are organized. And then metaplasia is usually something reversible, reversible cellular adaptation of some type. It's going to be replaced by another cell. All right. Disruption of homeostasis. So when we talk about homeostasis, remember, not too hot, not too cold, just right. Right? But if you get too much fluid in, or you lose too much fluid out, it's going to cause issues. And it's also going to cause issues in different types of people. If I have a renal patient who's on dialysis and I decide to start an IV and give them 3,000 milliliter bolus, you better believe it's going to affect their homeostasis, right? They can't get rid of fluid already, and I'm going to overload them in fluid. So that's one thing you got to look at, is what kind of medical condition does my patient have? But then you got to flip it, and we're going to look at the size and the age of the patient, right? Somebody 240 pounds is going to need more of a fluid bolus than somebody who's 90 pounds. If we look at age and size, your book says a full-term neonate is 80% fluid, total body water, and their weight. So it's mostly water. So you got to look at a kid who's dehydrated and fever, because if their fever's up, they're going to be burning that fluid up a lot quicker. All right. And so if I have a 2-year-old that's 30 pounds, who's got a fever of 103, has been vomiting, I got to take that seriously. He come over to my house and I've got 102 fever. Well, man up, right? Maybe not. But you look at it completely different. You have to. right? You have to look at that kind of thing completely different. And that, like I said, underlying medical condition. I mean, you know, if I have a history of COPD and I overheat, I'm going to be a lot sicker than if me or you overheat. All right, so that's the stuff that they're talking about. Edema. Edema. Let me erase this. So when we talk about edema, what are we talking about? We're talking about swelling, all right? And so there's causes of swelling. All right, so let's talk about it. Increased capillary hydrostatic pressure. Do you guys remember what that is? All right, so if you don't remember, let's look at it. So when we talk about hydrostatic pressure, we're talking about the force on the vessels, and that force comes from how hard that left ventricle is contracting. Okay, let me erase this. Man. All right, we're talking about how hard that left ventricle is contracting. And so normally what? Normal blood pressure 120/80? Well, let's say I've got a pressure of 160/110. All right. So what does that tell you? One, systolic blood pressure. It represents my left ventricle and how it's doing. Okay. If my left ventricle is pumping strong, it's going to be above 120. If my left ventricle is not pumping strong at all, it's going to be less than 100, right? Now let's look at that diastolic blood pressure. That is a representation of vessel diameter. We talked about it, right? We talked about vasoconstriction, right? So we're going to vasoconstrict if we're in shock, but we're going to vasoconstrict if we have high blood pressure. Those vessels become less pliable, and they tend to they shrink, and that causes the high blood pressure. So a regular congestive heart failure patient, let's look at it. I don't think I can do it like here for now, maybe. All right, so we have the left ventricle. Oh, why do I do that every time? Left atrium, right atrium. We're going to have the left ventricle, right ventricle, right? All right. Oh, God. Man, I am so sorry, guys. I know. You would think I was like on drugs or something. You know? I don't know what's wrong. Sometimes I don't know. Don't know what's wrong with me. All right, hang on. What do we got here? All right, let's start over. All right, right atrium, right ventricle, left atrium, left ventricle. All right, that's how the heart works. That's your chambers. Now, we know that the aorta, right, that left ventricle pumps to that aorta. Has oxygenated blood coming through. Now, I want you to notice something. There's this curve in the aorta. The left ventricle on a good day has to pump blood, and it has to make it up. It's going against gravity and over the curve. That's on a good day. So let's say there's a problem. Let's say that we are experiencing some type of left ventricle problem. Our blood pressure has been high for a long time, and our left ventricle had to not just pump against that, but our left ventricle has to pump against the pressure of the system, right? Imagine the box here, and it's pressurized. And it's pressurized at, we'll say, 120/80. But if this pressure in this box goes higher, this left ventricle has to compensate for that and pump against it. All right, and when it does, it's like going to the gym for the left ventricle. It starts going and working out. And just like any muscle, when it works out, it gets bigger. And that's bad for the left ventricle because it's not designed to get bigger. It's designed to stay where it is. But as it grows further out, it gets sloppy, and it starts having trouble getting blood up and over. All right, so think about it now. The left ventricle is pumping in overtime. It's pumping hard. It's pumping strong. You got blood coming over. It's pumping against the pressure of the system. What happens into that blood once it gets pumped around the bend here? It is going fast. So we're going to increase the velocity. We're going to increase the velocity of that blood coming down. So here it's fine because it's a big aorta. But when we get down here to the capillary level, and it's water hammer, literally. And so what happens? Well, what happens is you're not going to have your whole blood escape. All right, you're not going to lose your cellular components. It won't go through the membrane. Okay, your white blood cells, your red blood cells, and your platelets. But what you will lose is water. And plasma is mostly what? Water. So that plasma is going to leak through. Has nowhere to go. Water hammer. It gets smaller capillaries. It's going to get forced out into the extracellular fluid. That's not a good word. The intracellular component part, interstitial tissue. Thank you. And that is going to go to your feet. Because that's edema. It's going to leak. It's going to go with gravity. It's going to end up at your feet. You do have upper extremity edema too, but it's harder to see. Okay, that is hydrostatic pressure. That means you got some issues going on. And that's a cause of fluid. All right, decreased osmotic pressure. Okay. Well, if hydrostatic pressure is going on, that oncotic pressure that's designed to keep the fluid in those capillaries is decreased. And then your albumin is decreased, and it can't retain. It can't keep the fluid in where it needs to go. But correct the left ventricle problem, and albumin comes out, and it will draw that fluid back into the system. That's how it gets back. That's how you don't swell. So that is what that is. All right. And then your lymphatic system, because you have that lymph fluid, right? You got your lymph nodes, right? And all that. Well, you have lymph fluid. Remember, it contains white blood cells, helps to fight infection. Well, what happens is, if you got a problem with your veins, maybe you have a problem over here on this side. This side's over here, okay. It has a hard time returning that fluid back up. And then we have something called unilateral edema. Means you'll have edema over here, but not over here. All right. All right, other causes of edema. I'd say there's some edema right here, right? Anaphylactic reactions, because you're having a major fluid shift,